Hello everyone, this is Celeste Binfield and
Josie Plazlewski.
And this is our analytics project. So first we had to start with 2 research questions, and the 2 questions we picked were what is the relationship between patient satisfaction and finance, and the other question is which types of hospitals had the best satisfaction. We chose these questions so that we would have a quantitative and qualitative measure. By having these 2 measures, we wanted to be able to quantify a qualitative measure. We also wanted to choose 2 questions that were related to one another. So the next step, we chose 15 variables that directly relate to these questions. So for our 5 satisfaction variables, we chose nurse communication, doctor communication, staff response, overall hospital rating, and cleanliness. For 5 financial, we chose salary expense, operating revenue, operating expense, net income, and non-operating revenue. And for the 5 quality variables, we chose accidental cuts and tears from medical treatment, readmission for the whole hospital, serious complications, deaths among patients with serious treatable complications after surgery, and serious blood clots after surgery. The next step was to investigate the variables and see which ones have a relationship. So then we go into the exploring section, and we analyzed all 15 variables in a univariate analysis. We determined the mean, distribution, and outliers, which were only for the finance variables. We adjusted each of the finance variables. After completing the univariate analysis, we started testing dependent and independent variables through a bivariate analysis. This is where we found a strong correlation between physician communication and readmission rates. The higher the physician communication, the fewer admission rates hospital-wide. We developed a hypothesis to test based on this initial finding.
So next, this is when we found, in our testing section, we developed our hypothesis based on that patient satisfaction is linked to these 2 variables, because once they leave the hospital, they do not want to come back. They want to be healthier leaving than when they were admitted. Financially, the hospital wants the same thing. They lose money if they are readmitted within 30 days of discharge. This is how we related our hypothesis back to our original 2 questions. So our hypothesis is if physician communication increases, then the number of readmissions for the whole hospital will decrease. Our independent variable was physician communication, and our dependent variable was number of readmissions for the whole hospital. After we did the regression, we found that our hypothesis was confirmed by the results, and physician communication was significant. We were able to determine that it was significant because the PR value was less than 0.05. As physician communication scores increased by 1%, readmissions decreased hospital-wide by 0.06. We did have to exclude outliers in this regression, and they were physician communication and by greater than or equal to 85 and less than or equal to 97, and our readmission rates were narrowed down to greater than or equal to 13 and less than or equal to 18. We picked these numbers because in our exploring section, they were in the 1st and 99th percentiles. Other variables that were found significant were Medicaid payer mix days, bed size, for-profit organizations, COTH, which is whether the facility has membership in the Council of Teaching Hospitals, and rural hospitals. So our proposed policy is physicians must communicate with their patients about their diagnosis, course of treatment, follow-up care, medication instructions, future potential preventative measures, and consequences if they fail to abide by those recommendations. Physicians should spend an additional 5 to 10 minutes with the patient to ensure that thorough communication is being achieved. By spending additional time with the patient will be healthier, have a better relationship with the physician, and increase their quality of care. If overall admission rates decrease by 1%, then a financial incentive will be provided. So there are some So there are a couple potential issues that may arise after the implementation of the policy. They may see it as administration is interfering with patient care. The physicians could reject the policy altogether. The argument that the physicians may make is that they already communicate effectively with their patients. Financially, the hospital could save money if their patients are not arriving back at the ER within 30 days. It could cost the hospital money to train physicians on how to execute the new communication policy. However, spending extra time with the patients could reduce the amount of patients a physician could see in a day. The extra 10 minutes could be spent with another individual. However, the trade-off could be that they are not readmitted within 30 days. The patient and the physician both benefit from this. The patient has a better understanding of their own health and how to manage it. Their health literacy could also increase. Patients could organize their health information and understand the importance of managing their treatment after they leave the hospital. The physician benefits because the overall health of their patient could be better, which is ultimately what they want. And they could follow physicians' instructions, take their medication as prescribed, and educate them.
So then we go to our experiment that we would complete. But before you complete an experiment, you first have to ensure that it is random. We will randomly select patients that have stayed at 10 different hospitals. But these hospitals cannot be selected completely random, because if you were to select 10 random hospitals across the United States, there's a great chance that those 10 hospitals would not be a good representative. So we picked 10 hospitals that are alike, and they are average hospitals, meaning they are not too big and not too small. So that the 10 hospitals represent an average amount of data across the U.S. 5 of these hospitals are going to implement the policy, and the other 5 are not, so that we can analyze the difference in readmission rates. We will choose 500 random patients from these 10 hospitals and view their charts. We will focus on looking at the readmission rates of these patients and analyze if the physicians were communicating well enough for a 6-month time span. In this experiment, the independent variable is physician communication, and the dependent variable is the outcome, or what we're trying to affect, and in this case, it is the number of readmissions for the whole hospital. We know that we can measure this by proving that if X causes Y, then Y also causes X.
So the importance of the policy is that if the physician communication increases, then hospital readmissions will decrease. So physicians should clearly communicate with their patients about follow-up care, their medications, preventative measures, and the consequences of failing by not abiding by the physician orders. Effective physician communication can facilitate a more accurate diagnosis, counsel the patient, and establish a relationship with the patient. This can also improve the health literacy of a patient so they can manage their own health more effectively. Physician communication is linked to patient satisfaction. Readmission rates are linked to finances of the hospital. So the hospital can generate more revenue if they're keeping patients out of their emergency department longer. When patients have better outcomes, they have higher satisfaction ratings. Are there any questions?